Suppose you repeatedly take that particular test on the same eye at the same city, 3 to 4 readings.
Dial. So you can mark the 0, 180. Also, you can mark the desirable axis. So what I have done, I have actually run it on 50 eyes. So this initially I was doing it using a 3D printed model and the stainless steel. Now the good part is that the dial is now become smaller. So if you saw the first prototype and the new prototype, the dial has become smaller. So if you're talking about repeatability, it's difficult to do it on the same eyes every time, but I have compared it with the Varion. So I have a study which I presented in the paper. So I have compared 50 eyes using this and 50 eyes using a anterior stromal puncture, compared it with Varion. The deviation of axis with our marker, the least deviation is 2.07 degrees as compared to an anterior stromal marker which went to around 4 degrees almost. So this the good thing is that there is no cyclotorsion. Number one, the patient is more comfortable. We ask the patient to align the lateral canthus to the mark on the slit lamp, so that acts like a bang on target. And also the patient is very comfortable because we put a proper barricade. We don't need to put a speculum also because the dial is very small. And the traumatic edge actually goes and indents the cornea. So even if you put paraffin, it doesn't
What
go
do
away.
you, Dr. Rohit?
So, thank you, Dr. Prakash. There was a question.
So you take the marking or directly implantation and primary
Depends.
incision?
You can do all three, sir. Depends on surgeon to surgeon. I usually take a 180 and a 90 degree, and then probably check it on the table. That's what I
So
usually
you do two-step marking?
Yes,
One in
but with
sitting
this,
and then another
yes,
on OT?
yes, but with this, I have started doing the exact placement, because if you see the dial, there are Epsilon has done a great work. They've actually put micro marks. So even if it is 127 or 126 degree, you can mark that as well. Go and please do that.
So this slit lamp marking was first started by me. I presented in EACRS 2012
Okay.
by with the help of Sinski hook. Just rotate the slit at desirable axis. If you want to take incision at 145, dial at 145, just mark at 145 single mark.
Works very
For
well.
lens implantation, you just mark two
Yes.
at 180 degree apart.
But even
So-
with this works very well.
So even without this, only with the help of Sinski hook, you can mark 3 marks on the cornea in sitting position,
But
and
that-
then you don't need to second in lying down position.
Sorry to
this
interrupt, sir.
Only 3 marks.
Sorry to interrupt, but with this it becomes easier, because when the patient is sitting, when you try to mark, the patient may jerk and move. So this has support of the slit lamp, so you can also put a band. So that is the additional factor in this. If you mark just
we
like
usually don't need.
So, okay, I think,
okay,
thank you.
thank you.
We'll go on to the next. Dr. Arvind Moria will be speaking on the Advanced Terminator Chopper, a new and novel chopper in the management of mature hard cataract. It will be discussed by Dr. Virender Agarwal. Thank you, Dr. Neeraj. That was an excellent presentation. Great
Greetings,
innovation.
volume. Volume. Greetings, everyone. In this film, we aim to demonstrate our new innovative surgical technique using advanced terminator chopper for chopping of mature hard cataracts. We have no financial interest. The rock hard cataracts are always difficult to crack as being stronger in compression but weaker in tensile strength. It is always difficult to crack them with present chopping techniques and instruments with chances of many well-known complications. But according to the rock excavation system and theory of the diffraction, it is always difficult to crush incised skull and segment in these rocks with compressive forces, but much easier to break and crack inside out dispersive mechanical forces. Breaking and cracking is much easier when mechanical forces are applied at the open edge on maximal weak points in form of micro notch or micro grooves at the surface of any hard material. So, there are many specialized West tools available which are pushed in the natural or different grooves with the help of blunt hammer-like objects, leads to crack these hard rocks under tension, and complete split is achieved in no time. Terminal chop is a new surgical technique developed by Dr. Rajendra Prasad, works on the principle of secondary rock breakage system with concentrated dispersive forces to crack these unbreakable hard nuclei. In this technique, similar to cracking and breaking these solid hard rocks, a unique dispersive mechanical forces are created to initiate a full thickness crack at the weakest, soft, thin equator, which simply traverses through the entire nucleus, breaking it into two complete pieces. Mechanics of terminal chop initiate a tensile fractures in a more direct manner from the equator parallel to the nuclear surface in a very efficient, least manipulative, and minimal use of phaco forces. Unlike in the vertical and horizontal chopping, neutralizing high compressive forces with high stress in these type of hard nuclei. So, there is a specially designed advanced terminator chopper developed by Dr. Rajendra Prasad with blunt olive tip to safely hook, hold, and stabilize, and then initiate a crack at the equator of the nuclei. The mode of action of terminator chopper is similar to drag tool, generating stress at the site of initial groove in the direction of the equator on the other side parallel to the nuclear surface to create a tensile fracture and divides hard nuclei into two complete segments. In this new innovative surgical technique, both the phaco probe and the advanced terminator chopper are always parallel to the iris plane as compared to the other chopping techniques like the vertical and the horizontal chop. Thank you so very much.
Thank you, Dr. Virender. Any comments?
Yeah. So, Dr. Arvind, this is your technique, or you are just representing the technique of Dr. Rajendra Prasad?
No, it has been developed by both of us.
Okay. So, what is your addition into this?
Yeah, so we have made it economical, and now it is this is the chopper. So it is made of steel now. It is a curved here, and we have made more blunt. And
Yeah.
the tip is more smooth.
Yeah.
Right. So there is no trauma in the posterior capsule. So it
No.
better grip.
So, what is the length of this?
This is 104.
No, the length of the vertical part.
This is 1.4.
So, length is 4 millimeter. So, it will not touch the posterior capsule. All the choppers are around 1.4, 1.5. So, there is not the risk. The only question, only my question is that the terminator chopper, you have made the top end is also blunt.
Dr. Arvind, could you go to the mic? That
It
would
is
be
not
better.
sharp.
Yeah.
So, it will not accept the holding.
Otherwise, doing the horizontal chop with the same chopper, applying the same forcing. The only difference is that you are saying that you are able to really go between the capsule and the nucleus itself.
Horizontal chop technique and the horizontal chop technique, the phaco probe is deeply ingrained.
No, it can keep, it is depending on the surface.
Yeah,
Maybe you want to
but in this technique, only superficial impairment of the phaco probe as well as this chopper. So it is parallel to the iris plane, right?
then you have to keep otherwise you will stress.
Yeah, and in the vertical chop, the direction of the sharp chopper is
Vertical we are not discussing. For hard cabinets you require a horizontal.
yeah. So horizontal chop, the direction of the phaco probe is deeply ingrained and towards the octopus. Whereas in this technique, only superficial impairment.
So what is the requirement? You say that the phaco should go to 1/3 of the nucleus, 2/3 of the nucleus, half of the nucleus.
Superficial impairment, only one third.
Okay, thank you.
Any other questions? Okay, thank you. I'll in the meantime request Dr. Sushmita, our co-chairman, to please come on the dais.
Yeah. So we'd like to now invite Dr. Prithvi Chandrakant. Yes. He'd be speaking to us on the slit scope, and the discussant would be Dr. Naresh Babu.
Start.
The presentation.
Good morning, all. No financial interest and no conflict of interest. I'll be talking about the slit scope.
Can't hear you.
Hello. Yeah. I'll be talking about the slit scope.
Only question.
So we all know that when we go to the outreach programs for camps, the only instrument that we actually have is a torch. Other than a torch, we don't have any other instrument, and taking a slit lamp is very bulky. It's very problematic. It could actually damage the slit lamp. So the problem statement was, can we replicate the slit lamp? So the solution we came up to was to three things: magnification, slit illumination, and imaging device. So we already have a imaging device which magnifies as good as a slit lamp, and that is anti-segment photography with the intraocular lens, where we use a small chart paper into which intraocular lens is pasted. In between it, around 15 or 20 diopter lens, and this will help us magnify the image once we put it on the smartphone. So the other problem was the slit illumination. This is where we are all lacking to replicate the slit lamp, and we introduce you to slit scope. These are my co-authors, and so we opened up the slit lamp and saw what are the illumination parts designed over there. So we had the LED bulb, a slit, and the lens. Over here we use the intraocular lens for the optics. Here you can see we use the slit over here, which was made using a chart paper. This one was a cut piece of a marker, and this is the intraocular lens. So with this, we made the adapter, which actually brings us the slit. As you can see over here, we could actually get the slit of the slit lamp. So this is the first image that we made. This was a slit of my own eye, and so after that we thought, let's make it more stable and make it 3D printed. So we actually 3D printed it with different diameters. Over here you can see the 1 millimeter circle diameter, here 1 millimeter square diameter, and here you can see a slit of 1 millimeter. We have even made 2 millimeter, 3 millimeter 3D printed adapters. So here you can see this is the adapter which is put onto the torch, and you can actually see the slit scope giving a slit. So this costed me around 350 with the torch. The torch plus the adapter 3D printed costed me around 350 rupees. And here are a few images. So with ASPI and slit scope, that is, we are not using any slit lamp, we could take images as good as a slit lamp. So these are the images which we took only with this ASPI device and the slit scope. You can see over here a corneal scar. We can actually increase the magnification by increasing the ASPI diopters, so that if we give 25 diopter IOL, we can even magnify it even more. You can see brown cataract and mature cataract over here. So this actually helps us in outreach programs where there is no slit lamp. You can actually magnify, you can take images, you can even grade the cataract, and this is very simple. It's very simple. You can just change. I have different adapters over here. You can change it to the desired ones, and then you can take images with this. It's cost effective. It is actually do it yourself, but we are even giving the 3D printed one, and it can actually be a very good alternate to the slit lamp. Thank you.
Thank you, Dr. Prithvi. Dr. Naresh, your comments, please.
So
thing is we already have.
Yes, sir.
Recommend that for taking it to the camps. I'm just asking.
Actually, there are handheld slit lamp, but I don't think everybody has it, and it's actually expensive. This is just 350 rupees. The whole setup is 350 rupees. If you're 3D printing
Yeah,
it.
the illumination. Can you adjust the brightness of the what illumination? It's a
At this point, yeah, we cannot actually adjust the illumination, but we can try something like including a filter which would actually reduce the illumination.
The question is, have you ever compared the luminescence of this with that of a conventional?
Yeah, we are doing a study in which we are comparing the LOCS grade cataract with the slit lamp itself.
No,
It's
then-
actually very promising.
And the filter, any the fluorescent staining of the cornea.
If we add a blue filter to the ASPE, we have already published an article in which we have used the blue filter on the ASPE. Then you can actually take the image of the person. Like to
Thank
see
you.
this?
You have a question? Sure.
Yes, sir. We'll just on this and then just take it like this.
Coordination between the two hands.
Yeah.
Coordination between two hands is required.
Yeah, it is required. Yeah.
This slit can be used with ophthalmoscope, direct ophthalmoscope.
Yeah, we can use it, but you will get only one particular diameter. But over here we have different adapters for different. You can have a circular one, you can have a square one, you can even have a slit one. Slit we can have 1 millimeter, 2 millimeter, 0.5. Can have different millimeters.
Any comparison using the ophthalmoscope slit and your slit? What the difference is?
Actually, the ophthalmoscope scope slit is a little more thicker. If you see this one, this is actually very thin. You can actually get a very good slice of the lens.
Okay, while using it, how are you going to adjust magnification? I mean, you have a patient in front of you, you have to assume that he's going to open his eyes very wide,
Yeah.
because you can't do that. On the slit lamp, you're using your
Yeah.
left hand
Yes.
and you're using the right
So if
for it.
it's a very uncooperative patient, then we might have
And how
to.
will you adjust for magnification on your phone?
Yeah, we can. We have a 20 diopter lens, and we can actually magnify and change the magnification.
The catch what she's pointing out is that we'll need another hand to
if it's
adjust the phone.
uncooperative,
But
yeah.
but I think, I mean, one of the problems that she pointed out is you could actually get a handle on which you could, a rotatable handle on which, so that again gives you a freer hand.
Yes.
Maybe next year we'll have you with that
Yeah.
and see you there. So thank you very much. Next.
Can't see it.
Arey, kya? So next is Dr. Kanika Chabra. She'll be presenting on RetiSurge, a model eye for dry lab training in vitreoretina surgery. And it will be discussed by Dr. Uni Krishna.
Good morning, everyone. Today I'll be discussing about RetiSurge, which is a model which we designed for early vitreoretinal training. Slides on. No. Slides are not moving. Correct. So as we know, vitreoretinal surgeries are complex surgeries where we need the focus of the retina with the visualization system, along with manipulation of instruments in an enclosed chamber. And novice surgeons face a lot of challenge in this. We had the traditional approach which was observing the competent surgeons and then directly attempting onto the patients. Second was the animal eyes, but they have their own limitations like availability, need for separate instrumentation, and poor visibility. Then simulators, though they are a great tool, but they are expensive and not readily available. Recognizing the limitations of all these approaches, we designed a simple, cost-effective model designed via 3D printing. So how is the model I made?
Is designed using 3D printing. An eyeball is sketched based on its anatomy, which is then incorporated into the CAD software with appropriate dimensions. The model consists of two hemispheres. The upper one is made up of flexible material, that is TPU, which has same tenacity as sort of human sclera. The lower part is made up of PLA. Preparation of the retina. A color printout sheet is folded into a hemisphere using the concept of tape cone wrapping. A 3D used to customize the fundus printer so that it fits perfectly into the eyeball model. For a realistic fundus image, it is printed on a PETG sheet and then shaped with thermoforming technique. The microscope handle cover is fitted into a cardboard box with a hole in the center. The model eye is then placed over this assembly. Two ports which simulate the superior sclerotomies are made in the eyeball using the 23 tricars. These ports allow the introduction of the instruments into the posterior segment. This assembly is then used in conjunction with the operating microscope fitted with the biome to visualize the posterior segment and practice various steps of VR surgery.
Now
The
coming
most
on to the
important
applied
aspects
aspect.
of VR surgery is the focusing and adjustment of the microscope to obtain an optimum view of the retina, especially the periphery. Beginners face a lot of trouble in this aspect, but it can be overcome with practice using this model. Manual dexterity is the basic skill required for all VR surgeries. This model helps the trainees to achieve the desired flexibility of the non-dominant hand required for performing bimanual maneuvers during these surgeries. Retina search can also be used to practice the basic component of core vitrectomy, that is, illuminating the retina and the vitreous to be removed without losing the focus of the microscope. Endolaser can also be practiced on this PETG film. The burns resemble those on the human retina, and the power settings are comparable with the real life scenario. Further, it helps beginners in developing the sense of awareness regarding the position of instruments inside the eye to avoid inadvertent complications like retinal touch.
Come on to the advantages. It is an economical model prepared from indigenous materials which were available in our hospital. It was reusable, could be sterilized by using ethylene oxide, and since there is no biological tissue, it can be used inside the regular operating room. Limitations include it cannot be used to practice all the maneuvers and simulates the fundus view of a aphakic eye. It has already been published in AIOS in 2021. Thank you.
Thank you, Dr. Kanika. Dr. Nair, please.
That was it's a really nice innovation, especially
Thank you,
for an early training in VR
Yes.
surgery. As long as we understand its limitations, what you can do, what you cannot do. I'm most interested to know how is the focusing. It's an aphakic system. How is the focusing? How is the visibility to the periphery using?
So the periphery focus is as similar to the routine normal eye, but yes, that aphakic thing which you are mentioning, as I mentioned, the limitation also, because we tried implanting an IOL inside, but we were unsuccessful.
Okay, and how is the depth perception when you go to the the so-called posterior pole here? Could a trainee pick something off the surface?
Yes, we attempted glue also. So for ERM, we are actually, the next would be that we are attempting to place a glue, and then with the forceps, we are planning to do an ERM peeling. And the next is that
Okay, so
we are working on it.
I saw a very elaborate tape around it to stabilize it on the
Yes,
bed.
sir.
How difficult is that, and is there mobility issues?
Yeah, the mobility is there because if the plaster is little loose, the entire assembly moves. So that has to be ensured that it's fixed properly and before we start, sir.
I think it's a very brilliant way to start VR hand movements before
Yes,
you
sir,
go
because-
into the surgery. Yeah.
Especially so the non-dominant hand part, because the early surgeons, the fellows especially, find it a lot of difficulty to use the left hand. I myself was in trouble, and then thanks to this device, I was
That's good. Thank you.
Any
Thank you,
any other comments? Yes.
Do you
Dr.
fill the
Ramesh.
eyeball with some gel?
Yes, sir.
What
Yes.
is the
Viscoelastic, sir.
But viscoelastic, will it simulate vitreous? When you're-
Sir, actually, the cutting is not there, but the illumination part, as I mentioned, like initial days when I was struggling with the focus part, that illumination with the use of the left hand, the light pipe, I was, getting stuck there. So this helped me illuminate it better, and both the hands, the coordination of both the hands could be practiced.
So one thing that can simulate vitreous, but it's a bit dicey taken, is egg white.
That's what
egg
I
white
So we cannot
simulates.
take it
Yeah, you-
inside the operating room.
That's
We
see,
thought so,
yeah,
but
so,
we
but
couldn't.
egg white is something if you can take
Cutter
it
was
outside.
cutting it
Yeah.
also. We attempted in the wet lab,
Yeah.
but we could not take it inside the operating room. And the microscope and the machine cannot be taken out. That's why we shifted to viscoelastic. It was safe to use inside the operating room as well.
Okay, thank you. Thank you so much. Very nice presentation. Would like to now move on. Like to invite Dr. Avdesh Oli for his talk on innovative and cost-effective battery and sleeves for tonopen to record intraocular pressure. And Dr. Sushmita ma'am would be discussing it.
Good morning, everyone. I'll be presenting innovative and cost-effective battery and sleeves for tonopen to record intraocular pressure. So as we know, tonopen is a portable device to record intraocular pressure. It can be taken to the cams and the wards. The recordings are objective and accurate. And but the only disadvantage is that it requires battery and sleeves for each record, which are not very easily available every time, like during the COVID times. And it also amounts to a recurrent significant expenditure. So our instrument was dead. The tonopen battery was discharged and it was to be imported, and it was not possible that time. The disposable sleeves were not available. So we innovated the replacement for battery and sleeves for tonopen. When we opened, it is a sealed patented battery compartment, and when we opened the battery compartment, we found that there were two simple 3-volt batteries as we use in the glucometer, and the cost of these batteries would be around 300 to 400, whereas the price of that battery compartment is around 16 to 17,000 by the company. So we carefully opened the battery compartment and then we replaced these batteries looking at the polarity, and it was sealed with micropore. Now the tonopen beeped back to life, but again we were stuck because we did not have the sleeves. The center blue one is the original sleeve, and the other options we tried were these birthday balloons, and even looking at the thickness, we tried a condom also, but they had certain aesthetic and ethical issues also, but we could use these. But finally we came down to using the cut finger of the surgical glove, which was sterile and easily available, and one glove could give us 10 sleeves for the tonometer. This is a short video how we went about it. So this we found was the most suitable. Then we did a small study and compared the results with the original sleeves, the Goldman application tonometry, and the glove sleeves, it was found that the intraocular pressure, there was no significant difference statistically, and this is a box plot of the intraocular pressure which we recorded, and there was a significant correlation which was statistically significant. So the cut finger of the surgical gloves was easily available, sterile and cost effective, and it was a suitable replacement. And also the batteries with this method were very cost effective. Thank you.
Thank you, Dr. Saab. Indeed, low cost and effective. But the first question is, as it is, the tono pen is not used routinely in clinical use because the intra measurement variability is so high. So if I do my tono pen now and I do it 1 minute later and then 10 minutes later, the variability, so it hasn't really caught on, which is why the eye care has taken over most of the world. That's one. So I would be interested in what the variability is across time, 1 minute, 2 minutes, 5 minutes, if it's as good. And the second point is, when we are comparing different instruments, we need to do something called a Bland-Altman agreement.
Yes.
I am more interested in whether it agrees with a tono pen original sleeve and a tono pen modified sleeve that you've made, because correlation is easy. RNFL thickness increase karta hai, to something else might also increase, but they are not interchangeable. So those are the 2 points that I would make.
Yes.
Right, as she's pointing out, I mean, the tono pen may be kind of calibrated for the thickness, the tensile strength, the all the other parameters, mechanical parameters of the original sleeve, and that might change. Anyway, it's not such a great device, but anyway, any other comments? Great innovation, very nice for jugaad, as we call it, but as I said, it is a little bereft with the issues that need to be resolved before we can actually, talk about it. Anybody, any other comments? So, thank you.
Thank you.
Yeah, I'd like to now call Dr. Pranesh Ravi. He'd be speaking on DIY Lippy View from Ideation, Pitfall, and to Triumph. Is he here? No. Second also is Pranesh Ravi. Dr. Anjali. Yeah. So Dr. Anjali Khadla, she would be speaking on an innovative way in teaching examination of strabismus for residents, and Dr. Rakesh Shakya would be discussing.
Good morning, everyone. My presentation is an innovative ways in teaching examination of strabismus for the resident. I have no financial disclosure here. So learning sensory and motor examination of strabismus need time and practice, and it is difficult and not always possible to teach the concept with the real patient. So we demonstrate sensory and motor adaptation examination. First, to know how to make prism into strabismus. This is the orthotropic eye. So when is basin prism is placed before the right eye retinal image that is displaced nasal to the fovea, and due to the Hering's law, left eye moves nasally as image displays nasal to the fovea. With the help of, we demonstrate the strabismus examination. First one is the red glass test. This is the red glass interpretation. And when base in prism is placed, we making the isotropic, we see the homonymous diplopia. And when the base out is prism is placed, then we making the exotropia, we see the heteronymous diplopia. Similarly, for the base of prism, we see the normal retinous correspondence. Second one is the Maddox-Rod test. Maddox-Rod test, this is normal Maddox-Rod. There is the point source of rise is become the straight line according to the placement of the Maddox, whether it horizontally or vertically. And when the base in prism, obviously that is the uncrossed image, and base out with is the crossed image. And third one is the Begolini stripe glasses. This is the interpretation of the Begolini stripe glasses. This is normally we see, this is the orthotropic eye. And when one eye is occluded, obviously we see the one image, and there is the suppression eye. And base in prism is placed, making the isotropic. We see the image will shifted one side, same side, and both prism is placed in the base in. Then we beautifully see the V pattern. And when the eye is making exotropia, we see the opposite side image, and base out is prism is placed we see beautifully A pattern. Fourth one is the after image test. So it is very simple to test. So it is the torch light with black paper. It is the horizontal slit. The 2.5 millimeter in the diameter centimeter, and 0.25 it is the width, and central tape is to protect the fovea. First one is stimulated for the vertical slit, then followed by the horizontal slit, and then for the 20 second, and then close in eye, both eye, or just open the eye in the dark room, so that we see the beautifully this normal retinal correspondence. We induce the isotropic or exotropic base in, base out. We see similar image, but we are not able to demonstrate the ARC, abnormal retinal correspondence. So we did the study. So study group better performance after this evaluation. And coming to the discussion, this is the subjective assessments, and examiners feels the real appearance of the examination of the strabismus patient, and it will train the residents without a specific stimulators. So here I'm conclude that it just allows the residents to examine and diagnose the strabismus, and we can also demonstrate diplopia and HChat, but only for the paralysis, paralytic horizontal paralysis, not for the vertical strabismus. Thank you.
Thank you, Dr. Anjali. Before Dr. Rakesh discusses, I must congratulate you. This is the first time I'm seeing strabismus coming up on innovations. And personally, I'm very, very happy to see that there are people in our specialty also who are looking to bring about innovation. Dr. Rakesh, please.
Yes, a very congratulations to actually very good innovation. And my question is, some pediatric patient is very irritative. So can we do in this type of patients this examination?
Children is very difficult, sir. Less than 10 years, but above 10 years, patient is cooperative, then we can do, obviously. There is no problem. It is only for the PG students, for the know the experience, how the exotropic, isotropia patient, that diplopia is there, no? So can feel that so that easy for them, for the exam point of view, or for the oral exam, or for the general practice.
Thank you.
Thank you. Not many know that Dr. Virender is an accomplished, learned strabismologist. Any comments, Dr. Virender? We know him as the ACE refractive cataract surgeon.
Yeah, I think this is very good. At least PG can feel themselves by doing it on the colleague, that what will happen when you put a prism.
Yes, sir.
Actually, otherwise it is difficult to remember. Doing practical will make it simple.
Yes.
And the good thing is that everything is available at hand. Yeah.
Great.
Thank you, sir.
In the after image test that you were showing, it was a very nice one because not many people do that. Just remember the room should be dark.
Yes, sir.
So the surround room should be absolutely dark. Actually, the video was showing a little bit of light.
Yeah,
so
light is there, but
so great. Wonderful. Congratulations. So thank you. We'll go on to the next, Dr. Shafina. She'll be speaking on aspirator, just push, a novel push technique aspiration tool, and this will be discussed by Dr. O.P. Agarwal.
Good morning all. I'll be talking about aspirator, a novel aspiration tool. In surgical practice, it is essential to have clear and bloodless surgical field. So the need of suction apparatus is an essential part of surgery. Ophthalmology as a surgical field will have a minimum amount of blood loss, like in cataract surgery, less than 5 ml, in orbital surgery, around 75 ml. But the challenges we faced are the delicacy of the tissue and the small amount of blood, and also in deep socket there will be pooling of blood and fluid, and the bleeding which may obscure the view, especially in orbital surgery which need deep tissue access. Over years, there are various aspiration tools discovered, like angiosterometer, manually operated aspiration tool, electrical suction pump. But the drawbacks are the amount of pressure will be higher, and the suction tip are very large, which is difficult to maneuver in small or surgical field. Aspirator, our innovation is made to solve these problems. It is an easy, do-it-yourself, cost-effective and efficient tool to aspirate small amount of blood, and it can be made using recyclable and easily available components. And it is made using a foot pedal, a DC adapter, a DC water pump, an intravenous set, a collection bottle, and a bottle stand. And how does it work? It works by direct current, which is connected by an adapter, and this adapter is connected to a foot pedal, which acts as an on and off switch. And this foot pedal is connected to a self-priming motor, and the aspiration end of the motor is connected to a tube, which is connected to an opening in the collection tube, which will create a vacuum inside the collection bottle. And there is another opening in the collection bottle to which the intravenous set is connected, which will collect the aspirated fluid inside the collection bottle. The other end of the aspiration tube can be used in the section surgical field. And we also attempted to try this in the operation theater in orbital surgery. This is the adapter, which is connected to a foot pedal. And this is the motor, and this is the collection bottle. And the bottle is a used saline bottle. Sorry. And we could see that the apparatus is effectively aspirating the fluid and blood from the surgical field, which may improve the field of view and also reduce the time of surgery. So the advantages are the surgeon can control effectively. The surgeon can control the aspiration effectively by the foot pedal as and when required, unlike the standard aspiration tool, which is permanently on all the time. And the opening the end of the drip set is very small and flexible, which can be easily maneuvered. And new IV set can be used for each surgery, which may avoid sterilization of the whole apparatus for each patient, and also avoid cross infection. And the entire apparatus can be sterilized by ethylene dioxide, and it is cost effective. The cost of the entire equipment is less than 1,500 rupees. And it can be used for surgeries like cataract surgery, dacryocystorynostomy, dacriocystectomy, excision biopsy, orbitotomy, evisceration. These are my references. Thank you.
What is difference with this our regular suction machines?
One thing is the cost. The regular suction machine costs around 20,000 to 25,000, and this is only less than 1,500. And the tip of the regular suction apparatus is made up of metal, which may get blocked, and it is very larger. And this is simple IV set, which is easily available and it can be easily maneuvered.
With that machine, with that metal cannula, we can attach this pediatric feeding tubes, 6 number, 4 number. Those are very fine, and that can be done with simply available suction machines also. But definitely this is good if we can get it in 1,000 rupees. Is definitely a cheaper version.
Thank you. Yes, Dr. Ramesh.
I am not a cataract surgeon, but why 5 ml blood loss in cataract surgery, and why you have to use this in cataract surgery? Because that was the first indication.
The main use in cataract surgery is pooling of fluid in deep socket when we are doing cortex aspiration. So most of the time during surgery, the sister tried to mop the fluid with cotton, or she tried to pull it using a syringe. So if this equipment is available, either surgeon or the assisting nurse can easily aspirate the fluid.
So thank you, Dr. Shafina. We'll go on to the next one. Dr. Atul is here. Yeah, he'll be presenting on 3D printed LAG, which is lens attachment guard, a novel protection system for lenses used in ophthalmology. Can I request Dr. Virender to please step in as a judge and comment on this? Dr. Sitanshu Mathur had to be unavoidably called for some other work.
Good morning, everyone. I request all of you to take your phone out for 2 seconds and kindly turn it around. So what do you see? Does it have a case or a cover? Is your phone protected? You all might be having expensive phones or normal phones, but you want to protect it, right? Then this innovation is for you as an ophthalmologist. It's lens attachment guard, a 3D printed attachment guard, a novel protection system for lenses used in ophthalmology. So how did this begin? It began when I saw lenses breaking in the retina clinic laser room. It can be due to accidental slippage, due to the patient factor or doctor factor. And all these lenses are very expensive, mind it. So we decided to find some solutions. First, we tried some soft flooring, so to give it a cushioning effect. Then we tried covering it with M-Seal, but then we wanted something more solid, something more robust. So we decided to design and 3D print a new novel adapter. We wanted a mounting mechanism to put it onto the laser slit lamp, and we went on to prototype and pilot test it. So we wanted the innovation to hold the lens firmly, easy to attach and detach from the lens. It should not interfere with the corneal contact region, and it should be either mounted onto the slit lamp or to the wrist of the surgeon, so that in case it slips, it doesn't get in contact with the ground or the floor. And it shouldn't be a hindrance to the working area. And obviously, in India and anywhere in the world, it should be a low-cost solution. So we first CAD designed it, then we printed it in thermoplastic polyurethane, and we developed the first prototype in Hackathon 2.0 last year. And it consists of 3 main parts: a winding clip, a thread lock, and a lens holder. You can see the PRP Mainster PRP 165 lens hanging from the Pascal forehead mount of the laser slit lamp. So how this is set up? So first you have the adapter. This is the first prototype, and we have to fit the PRP lens into the adapter, and then as you can see, it is ready for application. We have put a wire tag there, and we can mount it onto the forehead and then align it, and then you can start lasering. And it can be removed again. You can wash it. The visco can be washed off. So now recently, few months back, we went on to develop the next version, LAG 2.0, with assistance of Orolab. It has a thinner footprint. It is comfortable to hold and no hindrance in any case. You can see the thin footprint. It is really thin, but at the same time, it does the job. So why not? So we thought, we have protected PRP. Why not protect all the lenses? So we developed for 90D. And since some might be having a black 90D or a blue 90D, they might want to change the color, like you change the case of the your mobile phones. So we thought, why not do that? Why not give the surgeon more options? Youngsters might be wanting more colors, more modulations. So we also developed for 20D as well, to prevent it from inadvertent falls and breakage. So we thought, how about some aesthetic variations? We went on to design more designs and give it more appealing to the eye, and also appealing to the patient in pediatric clinics when you have something colorful to be used. So I believe this provides adequate protection for ophthalmic lenses, and various color options are available, and we plan to make it easy on the pocket. And a drop test with the lenses are pending. We are awaiting funds to acquire more lenses so that drop tests can be done. Drop tests have not been done yet. Thank you.
Thank you, Dr. Virender.
Yeah, thank you, Atul, for having an innovative idea. My only feel is that this is required for the lenses which are having a rim, like gonioscope or the capsulotomy lenses or these kind of lenses. But probably it's not required for 90D and 20D.
Yes, sir, definitely,
because
sir.
it will not make any difference to them except making them slightly more bulky.
Yes,
And
sir.
I don't know how much weight it will add on to the 20D, but that can also be an issue.
Yes.
So, but rest all the idea is good, because the lenses like capsulotomy, I got myself broken because it fell.
Yes.
And these are the things which are very costly nowadays.
Yes.
Almost capsulotomy lens is 40,000 rupees.
So the idea is
if you
mainly
really-
for those lenses, 90D and 20D, just like accessories.
Yeah.
Just you can give it as a gift to somebody, or just like a color. You can have a different colored 90D every time you
Another
go.
idea is to match the color with your dress.
With your dress, yes, very nice.
And you can print your
Thank you.
name also on it if you want.
Yeah.
On the lens.
And these can be removed easily, or
Yes, sir, very easily. Just
So
like
they
how
are
you remove your
flexible kind of thing?
Flexible TPU for now, but we are planning to make it into silicon. Silicon requires a hard molding printing, and so it's a more expensive process. So we are moving on to that
because
soon.
sometime when you are maneuvering to put the cover on it, it can have a reason for fall, because you are taking it out with some force. So I think be careful for that.
Just like we take out case from the phone,
Yeah.
similar mechanism.
Yeah.
See, if you look at the breakability of a lens, it is usually the contact point which breaks,
Yes, sir.
rather than the rim per se.
Yes, sir. Yes, sir.
Because those are all already in the metal. So adding to it is not going to help, except that it does not drop because of the string.
Yes, sir. For the
So the
PRP
only
and
purpose-
gonioscopes, the
Yeah.
aim is to prevent it from falling
Exactly.
down. And for the other lenses, it's just to give it an aesthetic appearance.
The only challenge is that even if it is suspending, when it drops down, it shouldn't hit the other part of the slit lamp.
Yeah, that is also, we might have to look at the So the arc, if you see, it's falling from the forehead. So when you look at the arc of how much, like a pendulum, if you see, we tried it once, like to drop it. It did not come in contact with any part of the slit lamp, laser slit lamps. We tried it on Iridex and Pascal slit lamp. It did not happen.
No, one question is, you said the young people like colors. What made you think that old people will not like
Don't
colors?
like colors. And you must be
His
very
complex
sensitive
is
towards your terminologies. You must know that all of us are on the better side of 40. So thank you very much.
Thank you.
We'll go on to the next one, Dr. Rubina. Is Dr. Rubina there? No. Okay. We have Dr. Dipankar Das, a brilliant innovator, academician, who will be presenting laser detection, a novel approach to detect microorganisms. The discussant will be Dr. Subhra Goswami.
Good morning, respected chairpersons and judges, ladies and gentlemen. I'll be presenting my innovation on laser detection and novel approach to detect microorganisms. I do not have any financial disclosure to present here. This is purely an academic one. Well, what we knew from earlier was, let us see the mycotic corneal ulcer. Now, this ulcer was scraped and in vivo fluorescent stain was done, and it was published because a fluorescent stain that we use in the IV was used to stain the thing, and this innovative publication we have published. Secondly, this is a evisceration specimen, and again a fluorescent in vivo stain was done, and this again this was published. This we knew earlier. Now, can we visualize microorganism without a stain? I'm speaking of a virtual staining. Now, this is the properties of light innovation of microbes and parasites, the cost-effective way I like to present here. Now, there are various uses of laser in ophthalmology, and currently microbiological staining in laboratory has been used since time. And we analyze the effect of laser in different microbes and parasites for their detection. Now, laser from the Pointer class 3 laser product, company 21 CFR and wavelength of 532 was used under the objective of compound microscope. Necessary eye protective measures were taken. Raw specimen and parasites were studied. They were examined in the monitor of a computer attached to the microscope. And the septate fungus, 8 cases were studied, and bacterial colonies were studied for 2, and parasites in 5 cases. All of them were confirmed with the conventional staining. This is the staining that we have seen in the corneal, and this is the fluorescent stain that here, and this is a clean laser when you use them. And you can see this is our innovative fluorescent staining, and this is a laser how the phthalates were screened there. So the inference of this innovation is that stainless laser, that is a virtual staining, and its modification could be helpful in future cost-effective diagnosis of microorganisms, including parasites in real-time live patients. So process of innovation are after a lot of basic experimental stage and scientific imagination. I like to thank cornea department, our ocular pathology department, microbiology department at C. Shankar Dev Netralaya. Thank you for patient hearing.
Thank you, Dr. Dipankar. Dr. Shubha.
Yeah, Dipankar, thank you very much. It's a really innovative trial. Have you had a long-term study of this efficacy, particularly the economical factor?
Yeah, thing is that the properties of light here, simple laser which is used class 3 laser. Now there can be modification. Suppose you use in the slit lamp, we know there are various filters, for example, gray filter, green filter, etc., which we can do in vivo staining. And so properties of light can be used in the future slit lamp to detect those fungus directly. So no, we may have a evidence before scraping is done that fungus is there, the various parasites are there in vivo staging. Because if we increase the magnification of the slit lamp to in comparison to the compound microscope, it will give a good corroborative evidence about it.
Do you have any other study about the reliability of the conventional method and this method?
No, this is we have studied in the compound microscope. So this innovation has to be done in the slit lamp and other thing in the future.
Thank you.
Thank you, sir.
Thank you, Dr. Dipankar. We have two missed talks. Dr. Pranesh Ravi has just joined us. So he'll be presenting two talks. His first one, he's here now. His first one is DIY LipiView from ideation pitfall to triumph. It will be discussed by Dr. Virender and Dr. Prabhu, if he can. Great, thank you. And also, I wanted to announce we'll be handing over the certificates of the participants to the judges or the discussants who had judged or discussed the paper, so that after this we can just hand over to the presenters.
I'll start, sir.
Yes.
Hi, my name is Dr. Pranesh Ravi. Today I will be presenting my Apple III presentation on smartphone meibography. These are some of the conventional methods of visualizing the meibomian glands. Most of these are expensive and cannot be incorporated easily in the consultation room. It all started with me trying to capture stars using my Pixel phone, but light pollution was always an issue in my city. I found out by blocking this stray light using an infrared filter, I could obtain better quality picture. I thought, why not use this to take an infrared photograph of meibomian glands? This was my eureka moment. I found out that all smartphone cameras have full spectrum cameras, meaning that they can capture all the light rays. My goal was to isolate only the infrared light and improve the image quality by changing the camera settings. I used this filter just like any other filter in a slit lamp. I had a lot of problems with capturing the images in infrared and also during conversion. A lot of trial and error was involved, and finally I landed at a sweet spot. All I had to do was increase the details captured through my camera. So I used these manual settings in the Pro mode. You can change these settings accordingly to get the best output image. I also realized that by using this filter, you can visualize the meibomian glands. So I use this filter for initial assessment, and if I find gland loss or tortuosity, I send them for an LipiView or kertograph documentation. The red hue is due to true infrared light being captured. I use Snapseed and editing software for the conversion of these images to grayscale. I have a preset setting so that post-capture, I just need to click it to apply the edit. I found a specific function with the software called structure. Only increasing this, I could acquire detailing similar to keratograph picture. Here are the final results and a comparison between them. You can see that images taken using the filter and the conventional ones are more or less similar. Photographs taken using this method have similar limitations to using an infrared camera. But seeing meibomian glands in real time using this filter saved me a lot of time for me and my patient. Hope you enjoyed this presentation. Thank you for your patient listening.
Thank you very
Thank
much.
you, Dr.
Thank you,
Dr. Virender.
Thank you. I think it's a very novel idea and a daily
Thank you.
required thing, because meibomian gland dysfunction is a very common thing happening. But the pictures you were showing are not.
filter here, sir. I can just if
No,
you
I
want
understand, but the filter has to be held in front.
yes, just like how we use a yellow filter, it has to be held in front. You
Yeah.
can see the meibomian glands in real time.
Okay.
There'll be a slight contrast difference. So you can clearly delineate tortuosity and gland loss. Both
Yeah.
can be clearly seen. Then you
That
can
will-
use for higher device to have a better capture.
Yeah.
I'm just finding methodologies for it to give a comparable image to a lippy view, because the concept behind lippy views, they do double exposure. They take two images and overlap it together.
Yeah.
For give the pronounced effect over the meibomian glands.
Yeah.
I'm actually working on it, sir. Possibly next year.
Can you use this filter on the back of the camera protector cover?
Yeah, sir. That's how I took astrophotography. I have a Pixel phone. I use that to take because it blocks all the stray light. Then you can convert it again.
Yeah.
You can use
So
very
the
much.
conversion is available in the camera setting or where?
No, that I've told the software, sir. It's Snapseed. You just
Yeah.
need to convert it into grayscale, and to pronounce the contrast in the meibomian gland, you need to. There's only one detailing called a structure, which is a proprietary thing in Google. It's available for free. If you increase it, it will clearly expand the delineation between the meibomian gland and the normal tarsal plate,
Yeah.
so that it'll appear more pronounced.
Thank you.
I actually started taking an imaging, sir. I thought of taking imaging. Then I found out that you can see the glands in real time. So that was really mind blowing for me. So I prognosticate with this. If I want to move further, I'll send them to a keratograph or a lippy view scan. Yes, sir.
How do you compare it with what we see with the autorefractometer?
Sir, autorefractor, two problems, sir. They use a 1.3 megapixel camera. The sensor is very small and you cannot capture the image. Three problems are there. I initially thought of doing that only, and these three problems will make your output also is very poor, and this output is far superior, sir. Depends upon your camera. You can play with the manual settings and you can get an excellent output, sir.
Thank you. Dr. Pranesh will stay on and present his next one, which is geoteeing in time saves 9, precedence and history taking. Dr. Prashant Bavanpale would be discussing that.
Hi, my name is Dr. Pranesh Ravi. Today I will be presenting my Apple Tree presentation on jotting in time saves 9. It will reiterate the importance of patient intake forms to speedline the patient consultation process. This graphic is a simple representation of the patient flow process in our hospital. In today's fast-paced society, patients increasingly find the longer length of their wait times to be frustrating. Now let's look at the optometrist timeline. It approximately takes 10 to 20 minutes for a well-fleshed-out examination of a regular patient, where initial assessment takes the maximum chunk of time. Is it possible to offset the time to improving chair time and also decreasing the wait time? I present you my Apple Tree take on improving patient outflow and wait time using readily available jot forms as a customizable patient intake form. This study has clearly shown the improvement in accuracy and error reduction due to incorporation of intake forms in the US healthcare system. This is a customizable template of our form used for the preambulation of the patient workflow. Most questions are clickable, easy to use. The best part about this is the patient can fill them at home prior to coming for a consultation by scanning the QR code or using the form link sent to them while fixing an appointment. Patients can also upload their prescription sheets, reports, and drops used prior. By knowing if the patient has come for a second opinion, I can strategically increase the chair time for that particular patient. Jot forms help you generate your own app for form filling. This is how the form through the app would look. At a click of a button, it can create a spreadsheet of all the details in real time. Even the photos uploaded can be viewed. These are various options to export your input data in the application. An Excel export can be done for analysis or data keeping. The above mentioned are some notable advantages of Jot forms compared to Google Forms, which are most commonly used today. These are other software integrations available in the platform. The most exciting feature is automation acceptance, where through the illustrated apps you can automate the auto entry of patient data directly into the EMR if compatible, saving a lot of time in data entry and ensuring accuracy as the patient's own data is being extrapolated.
Thank you, sir. Thank you.
Thank you.
Thank you. Thank you very much, sir. Thank you.
Exactly, I would like to understand the difference. Basically, if you have it, any forms which can be uploaded at home, the same thing you are doing, but it is getting integrated. That's what you mean with this particular software.
Sir, two problems I had, sir, with physical forms. The first
Not the physical form. If you
any-
accept any patient to Google form and this particular jot form, what is the exact difference?
Exact
in
difference?
integrating it into the MRD.
So it saves a lot of time, sir, because we are extrapolating the same information. The name, the address. I'm a center. I'm managing a whole center, sir. So I asked my receptionist, and what does take more time for you? She says I take more time in typing the address and the phone number, and the phone number is where they make most of the mistakes. So, and also these are two things which I found that in the initial workflow itself, if automated, it can be addressed.
That I accept. The patient himself fills the form for you. It's readily available. So
Yes.
what is the difference between jot form and a Google form? That's what I'm trying to understand.
No, jot form it's more integrated, sir. You Google form though, it's very limited. It's a very small structured form platform. But here you can use apps. You can use other apps to integrate with it. You can share it with a lot of people. My center manager, everybody can share. So they can actually see everything in real time. So Google Forms the reports are very small. You cannot export it into various formats. But this is much more expandable and it's much more versatile.
Because all the EMRs now have this particular facility already integrated in it. Most of the EMRs which they are customizing and giving you to the hospitals already has this integrated feature. That's what I'm trying to understand. Yeah.
But one more thing which I found, sir, this patients usually don't bring their medications or they don't bring their this one. So using this form, they can just upload those pictures, and also they can upload their own photographs, because certain scenarios and certain pediatric conditions you need to know how it was. So if we give this form, they can just take a snapshot or a video and upload it so that I can preempt them better. Yes, sir.
No, I register with you, but I don't come to you. How long you'll retain this form? What is the time gap? Because otherwise it's going to clog your server.
It will be there, sir.
No. If you keep on I'm not going to come to you, but just for fun I am filling the form. No, it happens.
Yeah.
So how long you will retain, and after how much of time you will delete it? Because otherwise your server will be filled with all this nuisance.
Sir, I have a 2 TB hard disk, sir.
No, that's okay. But we all learn with time that 2 TBs are inconsequential 1 year down the line, and we are struggling to retrieve data. But I guess
Photographs and videos cannot be retained for longer, but patient data can be retained indefinitely.
No, but that is the reason why it has to be. Because you said you have 2 TB. My first pen drive was 256 MB. Now it's of no use.
Yeah, Dr. Prakash.
I think simple question is there.
Yes, sir.
Patient has uploaded so much of information, maybe wanted or unwanted. Now the thing is, from medical legal point of view, patient may say that this information was provided to you, but you didn't read or you didn't take notice of this while treating me. What are the medical legal aspects about that?
Usually this form, after post filling, the optometrist looks into it, sir, and I correlate the information. Second problem which I found out is optometrists tend to miss past history very much, and I need to know if the patient is coming for a second opinion or a third opinion. That's what I can capture the patient. So these two things this form does.
Definitely a good thing. The only downside is that you still will have to spend time through this spreadsheet or whatever that is generated. So it of course would decrease the overall time.
Yes.
But yes, it would. So thank you very much everyone for being here. I'll just request the judges to hand over the certificates to our presenters. Dr. Neeraj may please collect the certificate from Dr. Prakash Marathe. Dr. Neeraj is here. Yeah, Dr. Neeraj, could you please just come up front and collect it from Dr. Prakash Marathe? Dr. Arvind Maurya can collect it from Dr. Virender. Yeah. आ जाओ. So Dr. Arvind, jaldi photo. Dr. Prithvi, please collect it from Dr. Naresh Babu. Dr. Kanika, Dr. Kanika, please collect it from Dr. Nair from Krishna. Dr. Avdesh, Dr. Marathi will have to do the honors. Dr. Sushmita is not here. Dr. Avdesh, nahi hai. Dr. Prasant, Dr. Ravi, Pranesh Ravi, Dr. Prabhu, and Dr. Prashant. Dr. Anjali from Dr. Rakesh. Come, Dr. Anjali. Dr. Rakesh, please. Dr. Shafina. Dr. Agarwal, please. Dr. Atul. Dr. Virender. We'll have a group photo after this. If possible, you can stay back. Dr. Virender, is he here? आजा डॉक्टर वीरेंद्र आप पीछे मत जाया करो पुरानी स्कूल की आदतें छोड़ दो बैक बेंचिंग की एंड डॉक्टर दीपांकर दास डॉक्टर गोस्वामी दो भाई सर्टिफिकेट वी आर डन विद सर्टिफिकेट Judges and everybody just
Participants. Dheeraj, yes. All of